Restrictive lung diseases. Acute and chronic. Restrictive lung diseases. Diffuse interstitial lung disease. A heterogeneous group of disorders characterized predominantly by diffuse and usually chronic involvement of the pulmonary connective tissue. Test. Obstructive. Restrictive. FEV1. VC. Slight or N. FEV1/VC. N or. Restrictive lung diseases. Definition. Reduced lung compliance. More pressure needed to expand lungs. Lungs are stiff. Pulmonary function test. Low FEV1, low FVC. The ratio FEV1/FVC at normal. Fibrosis, stiff lung, which level? Principally the most peripheral and delicate interstitium in the alveolar walls. Fibrosis. Stiff lung. This results in reduced expansion of lung with reduction in total lung capacity. Restrictive lung diseases. Characterized by reduced compliance of the lung. Caused by 2. Parenchymal disease, prominent changes in the interstitium, interstitial lung disease. 1. Chest wall abnormalities. Kyphoscoliosis. Severe obesity. Guillain-Barré syndrome. Guillain-Barré syndrome is an acute inflammatory demyelinating polyneuropathy, an autoimmune disease affecting the peripheral nervous system, usually triggered by an acute infectious process. Exhibits as an ascending paralysis noted by weakness in the legs that spreads to the upper limbs. With prompt treatment by plasmapheresis or intravenous immunoglobulins, the majority of patients will regain full functional capacity. Restrictive lung diseases, interstitial lung disease. Important signs and symptoms. Dyspnea. Hypoxia, caused by damage to the alveolar epithelium and interstitial vasculature, produces abnormalities in the ventilation-perfusion ratio. With progressive severe hypoxia. Respiratory failure and corpulmonal. Chest radiographs show diffuse infiltration by small nodules, irregular lines, or ground glass shadows. Restrictive lung diseases, interstitial lung disease. Chronic. Chronic inflammation and fibrosis. For example, pneumoconiosis, idiopathic pulmonary fibrosis, sarcoidosis, hypersensitivity pneumonitis, immune-mediated, SLE, chemical-related, berylliosis, acute edema in acute respiratory distress syndrome. For example, adult respiratory distress syndrome, neonatal respiratory distress syndrome. Chronic restrictive lung disease, chronic interstitial lung disease, are a heterogeneous group with little uniformity regarding terminology and classification. Chronic restrictive lung disease. Major categories of chronic interstitial lung disease, CILD. Fibrosing. Pneumoconiosis. Usual interstitial pneumonia, idiopathic pulmonary fibrosis, cryptogenic organizing pneumonia. Associated with collagen vascular diseases. Drug and radiation reactions. Granulomatous, sarcoidosis. Hypersensitivity pneumonitis. Wegener's granulomatosis. Eosinophilic granuloma. Smoking-related, desquamative interstitial pneumonia. Respiratory bronchiolitis-associated interstitial lung disease. Chronic interstitial lung disease (CILD). Many entities are of unknown cause and pathogenesis. Similar clinical signs, symptoms, radiographic alterations and pathophysiologic changes. Patient have reduced forced vital capacity, however the FEV1/FVC at normal. Account for about 15% of non-infectious lung diseases. Idiopathic pulmonary fibrosis, hypersensitivity pneumonitis. CILD. Idiopathic pulmonary fibrosis. Hypersensitivity pneumonitis. Smoking-related. Pneumoconiosis. Idiopathic pulmonary fibrosis, cryptogenic fibrosing alveolitis, usual interstitial pneumonia, UIP. A clinico-pathologic syndrome with characteristic radiologic, pathologic and clinical features. Radiology, bilateral lung nodular infiltrator. Histology, diffuse interstitial fibrosis and inflammation. Clinical features. Dyspnea, advanced cases result in severe hypoxemia and cyanosis. Males are more affected than female. 2/3 of PT. Older than 60 years. Pathogenesis. Some form of alveolar wall injury result in interstitial edema and alveolitis. Type I pneumocyte is more susceptible to injury. Type II pneumocyte hyperplasia, regenerate. Fibroblast proliferation with progressive fibrosis of intraalveolar exudate and intraalveolar septa. IG deposits are seen in alveolar wall. FGF, TGF, PDGF. IL-8 leukotrienes. Morphology of IPF gross. The lungs are firm. Pulmonary edema. The morphologic changes vary according to the stage of the disease. Early cases. Intraalveolar exudate. Hyaline membranes. Infiltration of the alveolar septa with mononuclear cells. Hyperplasia of type II. Pneumocytes. Morphology of IPF advancing disease. Organization of the intraalveolar exudates by fibrous tissue. Thickening of the alveolar septa owing to fibrosis and variable amounts of inflammation. Alternating areas of fibrosis and normal tissue. Geographic variation. Temporal variation. In the end, the lung consists of spaces lined by cuboidal or columnar epithelium separated by inflammatory fibrous tissue, honeycomb lung. Honeycomb lung. Prognosis of IPF. Gradual onset of dyspnea with respiratory difficulty. Hypoxemia and cyanosis. Core pulmonal and cardiac failure may result. The progression in individual cases is unpredictable. The median survival is about 2 to 4 years. Pneumoconiosis. Non-neoplastic lung reaction to inhalation of mineral dusts. Most common dusts are coal dust, silica, asbestos and beryllium. Pneumoconiosis. Occupational lung diseases. Dr. Atafali 2010. Pneumoconiosis pathogenesis. The development of pneumoconiosis is dependent on the amount of dust retained in the lung and airways. A. Concentration of the dust in the ambient air. B. Duration of the exposure. C. Effectiveness of the clearance mechanisms. The size, 1-5, shape. Their solubility and physiochemical activity. The possible additional effects of other irritants, tobacco, smoking. The particles are impacted at alveolar duct macrophage, accumulate inflammatory response fibrosis. Coal workers pneumoconiosis, CWP. Pneumoconioses. Coal workers pneumoconiosis, CWP. Silicosis. Asbestosis. Coal workers pneumoconiosis, CWP. Occurs in coal workers after many years of underground mine work. 2 forms. The simple form. Focal aggregations of coal dust-laden macrophages. Coal macules, 1 to 2 mm, mainly in upper lobes. Patients have slight cough and blackish sputum. Emphysema, smoking-related. The complicated form. With heavier pulmonary burdens of coal dust, fibrous scarring appears, complicated CWP, also called progressive massive fibrosis, PMF. Co-worker pneumoconiosis. Morphology. Complicated CWP. Black scars exceed 2 cm in diameter, sometimes up to 10 cm. It consists of dense collagen and carbon pigments. Pulmonary. Minors who have rheumatoid arthritis and PMF are called Kaplan syndrome, coal miner with progressive massive fibrosis, unstained. Co-worker pneumoconiosis. Clinical course. CWP is usually benign disease with little symptom. Minor cases progress to PMF. No increased risk to bronchogenic carcinoma. Co-workers pneumoconiosis, CWP. Pneumoconioses. Co-workers pneumoconiosis, CWP. Silicosis. Asbestosis. Silicosis, long exposure to silica particles. Nodular densely fibrosing pneumoconiosis. Encountered in a diversity of industries: mining of gold, tin, copper and coal, sandblasting, metal grinding, ceramic manufacturing, drilling and tunneling. Pathogenesis. Crystalline silica is highly fibrogenic. Scattered lymphocytes and macrophages are drawn rapidly with fibrosis. Some particles are transported to lymph nodes. Morphology of silicosis. Tiny collagenous nodules that enlarge, forming stony hard large fibrous scars, usually in the upper lobes. The lung parenchyma between the scars may be compressed or emphysematous. Calcifications may appear, eggshell calcification. Similar collagenous nodules within the lymph nodes. Fibrous pleural plaques may develop. Morphology of silicosis. Micro. Hyalinized collagen fibers around an amorphous center, fibrous nodules. Scarring progress to PMF. Scarring extending and encroaching the pulmonary arteries. Pulmonary. Clinical features of silicosis. Depend on form of silicosis. Forms of silicosis: acute silicosis, chronic silicosis. Results from exposure to high dose of silica, fluid in alveoli. PT. Have rapid onset of tachypnea, cough and respiratory failure. Chronic silicosis. Inhalation of silica for long time with fibrotic nodules, present in upper lobe of lung and in subpleural spaces. Complicated silicosis. Progression of chronic silicosis with PMF with chronic hypoxia. Other pulmonary disease. Increased susceptibility to TB. Kaplan syndrome, uncommon. Lung cancer. Silica and lung cancer. The relationship between silica and lung cancer has been a contentious issue, but in 1997, based on evidence from several epidemiologic studies, the International Agency for Research on Cancer concluded that crystalline silica from occupational sources is carcinogenic in humans. However, this subject continues to be controversial. Co-workers pneumoconiosis, CWP. Pneumoconioses. Co-workers pneumoconiosis, CWP. Silicosis. Asbestosis. Asbestosis. Asbestos is a family of crystalline hydrated silicates with a fibrous geometry. Two forms. Serpentine chrysotile, flexible fiber, more common. Amphibole, straight and stiff fiber, more pathogenic. Both forms are fibrogenic. Asbestosis. Inhalation of asbestos leads to asbestos pneumoconiosis. Pleural effusion. Pleural adhesions. Parietal pleural fibrocalcific plaques. Increased incidence of mesothelioma, bronchogenic carcinoma, laryngeal cancer. These consequences occurs decades after exposure has ended. An increased incidence of asbestos-related cancers in family members of asbestos workers has alerted the general public to the potential hazards of asbestos in the environment. Morphology of asbestosis: diffuse pulmonary interstitial fibrosis. Scarring containing asbestos bodies, ferruginous bodies. Asbestosis bodies, from human lung. Association of asbestos bodies with fibrosis, asbestosis. Pleural plaque in asbestos. Parietal pleura over dome of diaphragm, asbestosis. In asbestosis, PT. Develop progressively worsened dyspnea with cough and sputum progressing to cor pulmonale and death. Both bronchogenic carcinoma and mesothelioma develop in workers exposed to asbestos. The risk of bronchogenic carcinoma is 5-fold and for mesothelioma is 1,000-fold greater. The risk of bronchogenic carcinoma in 50x increased in smoking asbestos workers, but not that of mesothelioma. Malignant mesothelioma. Rare cancer of mesothelial cells. Arise from parietal or visceral pleura. Can arise from peritoneum and pericardium. 50% of PT have history of exposure to asbestos at work. It also appeared in relatives of asbestos worker or in people living near asbestos factory. The latent period between exposure and malignant mesothelioma is long, 25 to 40 years. Nearly all cases are related to amphibole asbestos. These minerals cannot be removed from the lung and the risk for malignant mesothelioma is lifelong. Simian virus 40, SV40, T antigen is found in 60 to 80% of malignant mesothelioma. Characteristic EM finding, numerous long microvilli on cell surface,